Good afternoon. I'm Stuart MacLeod. I'm happy to be here. I'm sorry I wasn't here for the earlier part of the meeting. The program certainly looks outstanding, but I've been getting in the mood to come here and present by participating in a review of an Ontario government program called OTAC, the Ontario Health Technology Assessment Committee. Some of you may be familiar with it. It was set up about a decade ago, really to deal in part with the issue we're addressing this afternoon, that is how to evaluate innovations, innovative approaches to healthcare, new technologies, and how to make a decision about which ones would really be of value to the citizens of Ontario and which ones not. And maybe I'm uniquely idealistic, but I find that somewhat refreshing. Most Canadian provinces, in my experience, have not been very enthusiastic in the last decade at looking at innovations in healthcare or giving equal time to the possibility that something may be of benefit and not just an added cost to the system. So it's been a very interesting couple of days, and I'll be happy to share with any of you afterwards my thoughts on the process. But it really is commendable that the province of Ontario is doing this. So I was pleased to be invited to be here to share some of my thoughts about innovation, the state of innovation in Canada. I have a variety of perspectives, as Dr. Stiller implied in my introduction. I'm really an academic. I'm a clinical pharmacologist, so I've been interested in drugs for the last 40 years, and they are a pretty good example of innovative technologies that appear from time to time in our healthcare system. But I'm also a vice president of the Provincial Health Services Authority in British Columbia. So PHSA is I guess in British terms you'd call it a quango, a quasi-non-governmental organization, but certainly we play a role in making decisions about innovations in the healthcare system, particularly as they relate to child health, women's health, mental health, cancer, infectious disease control, the things that PHSA is responsible for. And because of my interest in these kinds of topics, I've spent a lot of my misspent life in advising various levels of government in Canada. I've been on a number of federal committees. I was on the Premier's Council on Health Strategy here in Ontario, and of course I've done a lot of drug evaluation type of work. So that's enough of an introduction. I hope, as you're going to see, I like to use covers from The Economist to make some points. I've come to the conclusion over the years that The Economist is probably the best source of information about the healthcare system worldwide, and certainly they have many interesting insights. This cover comes from a year and a half ago, where they were talking about how we might cope with the data deluge. I guess for people of my vintage, we've spent most of our lives wishing we had more data. Now all of a sudden it looks like perhaps we have too much. Well, here's a couple of comments from what I've labeled as ancient wisdom updated. Galileo actually said, count what is countable, measure what is measurable, what is not measurable, make measurable. So that was, I'm not quite sure of the dates, but 4 centuries ago. Pretty good thought. In the 19th century, the second quote became quite common. If you can't measure it, you can't manage it. Now, anybody in the room know who this is usually attributed to? No takers? Well, I've always heard it attributed to Florence Nightingale. She's probably as good a source as any other, but if you delve into this very deeply, you find that there are a fair number of others who may have said it as well, and certainly it's not very much different from what Galileo said somewhat earlier. But here's the context in which Florence Nightingale might have said it. She, as you know, was a nurse in the Crimean War, and I'm not sure. I guess I don't have a pointer. Oh yes, perhaps I do. Well, it doesn't matter. You can see from this diagram, which is, or these are her diagrams of causes of mortality in the Crimean war zone in the 1850s. And the red part of the diagram represents deaths on the battleground, and the blue represents deaths that occurred away from the battleground. So obviously, she looked at this kind of data and drew the correct conclusion that it wasn't the wounds you suffered in the battle that were an immediate cause of death, but it was all the complications of wound care, of course, particularly tetanus and other forms of sepsis that were causing deaths. And in order, if you really wanted to make a difference in mortality, you had to address the infectious complications of wounds that were incurred on the battleground. You look like you have a question.
What were the dark areas?
I can't read it carefully enough, so I'm sorry. It's on the slide there. I think they're. No, I'm sorry. I'd just be guessing. But you can find this fairly easily if you just Google Florence Nightingale. These reports are there, and you can see the difference between the high point of the war on the right and the dying days of the war on the left. But in all time periods, the deaths were really of complications, and of course the major complication was poor health care, poor hospital care, poor standards of hygiene. Well, I think a lot of things have changed in the 40 years or so that I've been practicing medicine, and I actually don't go back to Rembrandt and the days of the anatomy lesson, but I sometimes feel like I do. But I use this slide often in talking about pharmacology to make the point that we've brought to bear new levels of scrutiny on new technologies. New technologies, I think, in the past may have been assessed somewhat casually. The technology here is representative of the new kind of drugs that we use. We've moved from small chemical molecules, relatively simple molecules, to highly complex proteins, antibodies, and so forth. This happens to be erythropoietin, but the real point I want to make is that we're exposing these new technologies to levels of scrutiny that were never, ever seen before. And I put this one in just to congratulate myself. I've been using the slide I just showed you for the last 2 or 3 years, but The Economist recently decided to put the anatomy lesson on the front page. And what you can't read probably is that the burgher of Amsterdam standing back with the paddles is saying, "Stand back, I'm a central banker." So if you believe that the central bankers are going to revive the world economy, we'll talk later. And clearly, and I'm sure you've been hearing this through the last couple of days, but there's clearly an active discussion going on within Canada at the moment about where we stand on innovation, how this contributes to our productivity, and this article appeared in the Globe in September from a couple of recent escapees from the clutches of the government, Kevin Lynch and Munir Shaikh, saying that, quoting Paul Krugman, is saying, "Productivity isn't everything, but in the long run it is almost everything." Strange then that with Canada's poor productivity and innovation performance compared with the US, that we remain so complacent. Where is our sense of urgency? And I suspect that most of you in the room, by virtue of your attendance at a conference like this one probably believe this, that the innovation and finding a mechanism for incorporating innovation into our systems is one of the keys to improving our productivity. And again, I've been an observer of the healthcare system for a long time, just about the same length of time as Dr. Stiller, actually. And when I started out, the power in this decision-making spectrum was all over at the right-hand side of this diagram. It was the major hospitals, the major teaching hospitals. It was the subspecialists in medicine who made most of the important decisions about new technologies and the adoption of new of innovations. But as you all know, the spectrum has really shifted. We've had an almost complete reversal of this paradigm, and now an awful lot of the influence on this is over at the left-hand side with patients, families, consumers, and most importantly with the people who are paying for healthcare. And in our system, of course, that's primarily the provincial governments. Well, bring you back to a home truth with which you're all probably familiar. There ain't nothing in the middle of the road except yellow lines and dead armadillos. This one is not just attributed to, it was actually said by a Texas senator named Jim Hightower. In my view, the Canadian health system has been trying to sit in the middle of the road, and that simply is not a good choice if we really want to make the health system sustainable. So I think one of the things that we have to confront if we're going to make the Canadian health system sustainable is how we approach innovation, how we evaluate innovation, and how we decide what to incorporate into the system. And I don't want to bore you at this time of the afternoon with a long discussion of how we evaluate innovation, but in my past, I was the Dean of Health Sciences at McMaster, which is, amongst other things, a highly innovative school in medical education, but also, I think, viewed by most people in the world as the home of evidence-based decision-making. And I think that concept of evidence-based decisions has served us quite well, but it really, it's a necessary but not sufficient condition. My point would be that we really have to look at evidence as one of the factors that informs our decisions, but if we sit back and insist in every instance on a complete evidence base before we make a decision, we won't make any decisions. I can tell you that most of the things I reviewed in the last 2 days from OTAC, from Health Technology Assessment in Ontario, there really wasn't a single one on which the evidence base is complete. Now, we happen to be looking at things that don't lend themselves very well to randomized controlled trials, but even in drug therapy, which does lend itself to randomized controlled trials, the evidence base is rarely complete. So I think we're going to see more emphasis in the future on comparative effectiveness studies. We're going to see less emphasis on RCTs, or at least less insistence on RCTs when it's clearly unrealistic to do them. I mean, one of my favorite gurus in this field is Jonathan Lomas, who some of you may know, who was the president for 10 years of the Canadian Health Services Research Foundation. And Jonathan really promotes the idea of using colloquial evidence, using real-world experience to help us make decisions. And I think it's very important that we embrace that approach if we're going to have an open mind on innovations, or at least if the payers and the major decision makers in the Canadian healthcare system are going to have an open mind. So I don't want to stand up here and disparage evidence-based medicine because it's done many good things for us, but I do think that our expectations of EBM have to be tempered by a sense of reality. Here's just my impression of some of the key challenges we faced. I think we have to do a better job of moving from what we know to what we actually do. I mean, we actually have a very substantial knowledge base about many areas of healthcare, but we don't always act on what we know. I do believe that we need to change our approach to looking at innovation. We need to embrace innovation as a way of driving competitiveness throughout the Canadian system and improving our productivity. We have to understand that different levels of government differ in their attitudes toward innovation. Clearly, the federal government is much more supportive of innovation right now than are most of the provincial governments. And coming to you as an academic with a lot of experience with reluctant colleagues in academia, I would say we need to do something to shift the attitudes of academics to this whole issue of innovation, productivity, commercialization of knowledge. I've said here that the attitudes that we encounter in academia are erratic. That's a euphemism, actually, or sometimes hostile, and they're sometimes very hostile. Really, this is perhaps a side issue, but the opportunities for anybody within the Canadian academic system to learn about leadership as it relates to innovation and improving productivity is very limited, and I guess that's what the Ivey School is really trying to address. Any of you who follow the discussion with the Canadian Institutes of Health Research will have seen this slide, and I don't want to belabor it, but it's actually quite a good depiction of what we're dealing with in the healthcare system. So we've done wonderful things on the left-hand side of this diagram. Basic biomedical research, basic science has given us a knowledge base beyond anything we could have dreamt of 40 or 50 years ago. We've done a reasonably good job, not a perfect job, but reasonably good job in investigating some of those new basic science breakthroughs and moving to validated clinical knowledge. So we've done clinical trials. We know what should be done. The real problem we have is getting through that next valley, which most people refer to as the second valley of death, going from what we know to work clinically to actually changing behavior, changing physician behavior, changing hospital behavior, changing patient behavior. Hugely difficult. And you probably can't see this very well, and it's a little late in the day to go through it, but this diagram actually stems from work that was done at McMaster about 30 years ago. So the loop in the lower right, it's labeled the clinical research loop. This is what my colleagues at McMaster used to call the technology assessment iterative loop. So any technology can be assessed in that loop, and then if you play your cards right, you move over into the left-hand loop at the bottom, which is the knowledge translation loop. So you make sure that you move from what you've learned in validation of a new technology to actually disseminating that information and applying it in healthcare in this case. But there's also a third component up at the top there, what Dr. Hartling in Edmonton has labeled as the prioritization and accountability loop. And that, I think, is sometimes the missing element in this. But really, the only point of showing you this is to point out that it is a continuum, that it's a complex system, and you really have to pay attention to all of the elements in here if you're going to introduce new technologies that meet an actual need in the healthcare system, validate them, and have them adopted in practice. So I want to come back just momentarily to innovation and productivity. Again, The Economist got it right. Actually, a very long time ago, I think about 20 years ago, this cover trade made the ship to go, but you notice that the lead article just above the ship says innovate and grow. And I think that's a good message. Here's just one representative new technology that could really make a difference in the health system. I guess it's not, perhaps you wouldn't consider it particularly new at this point in our history, but the development of mobile health, the development of cell phones and wireless technology and all the things that go with that really, I believe, hold the prospect for completely revolutionizing healthcare, certainly in North America and Europe, but maybe more importantly in the other parts of the world where communications and dissemination of knowledge have been particularly problematic. I made this point before that the academic world is in many cases inadequately supportive of innovation. I really believe this is a major issue that needs to be addressed. We university presidents, deans of medical schools, deans of business schools clearly have to concern themselves with the disconnect between their faculties in many cases and the realities of the challenges that confront Canada. So I'll leave this for the discussion. Just the glass isn't completely empty. I mean, Canada has invested a tremendous amount over the last 10 years in science and technology research and development. This is just a partial list of the kinds of initiatives that have been undertaken, not just by the present government, but certainly many of them started with the Chrétien government in the 1990s. And these programs have made an enormous difference, at a university level at least, in our capacity for science and technology. We actually have far more capacity to conduct discovery research, to develop new technologies than we've ever had before. And there's probably no better illustration of that than the Mars experiment here in Toronto. So there's lots of things we should be crowing about, but we probably haven't done as well with that foundation as we might have. And I think some of this is underscored by differences that we can see between Canada and the United States. I think our private sector has been accused of being relatively risk averse and of not participating as fully as it should in the sponsorship of new science and technology initiatives. And I think this is more true in health and life sciences probably than in any other aspect of our economy. In the United States, 25% of the GDP is generated by companies who are fostered in turn by risk capital. The comparable figure in Canada, I believe, is of the order of 2%. So we're really, we're not just victimized by our relatively small population size, but our aversion to risk. In fact, there are only 200 Canadian companies that account for 99% of the expenditure on RX&D, the private sector expenditure in R&D in Canada. And of those companies, hardly any of them are actually in health sciences. The ones that are branches of US companies for the most part. Canada, I think, has been slower than most jurisdictions to encourage lead institutions or to establish health science research clusters, the kind of thing that we really need to make major progress. And again, I guess Mars, the Mars district concept would be a good example of a life science or health science cluster. And I think we really lack an entrepreneurial culture in health sciences. A year ago, we did have a report on innovation in Canada from the Coalition for Action. The task force was co-chaired by Paul Lucas from GlaxoSmithKline. So there was some health sciences spin on it. David Naylor was a member of the committee, and you're probably familiar with the other members. But they came in with a series of recommendations that I think are pretty straightforward and intuitive, creating value through ideas, building Canadian global competitiveness and productivity, fostering more public-private partnerships, strengthening business-academic links. And again, that speaks, I think, to the point I was making a minute ago about the relative hostility of the academic world to this type of innovation. Launch a national learning and innovation initiative and expand the talent pool. Again, it's kind of motherhood, but here we are a year later, and I don't believe there's been a single action taken, at least I'm not aware of one, that's been taken that relates to this. And then here's the latest report from last month, and you perhaps have been talking about this during the conference, the Jenkins report that has come back to look at, to present a call to action from Innovation Canada. Lots of recommendations: create an industrial research and innovation council that has a clear business innovation mandate, and perhaps their major recommendation was for simplification of the SRED program, the Scientific Research and Experimental Development Program. As a pharmacologist, of course, I've been hearing this for at least 25 years, since a good part of the SRED is spent in pharmaceutical development. I think it's fairly clear that for the $3 billion a year that we're spending on SRED, we're not getting anything like the kind of payback that we deserve. Make business innovation a core objective of procurement. Transform the National Research Council into a constellation of large-scale, sectoral, collaborative R&D centers. Create those clusters we were talking about. Help high-growth, innovative firms to access the kind of risk capital that they need, and establish a clear federal voice for innovation, and engage in a dialogue with the provinces to improve coordination and impact. Well, I've been around a long time. I've heard most of this before, so I'll be happy to come back next year and give you my view on whether any of this has happened, but I sure wouldn't hold my breath. So those are my thoughts. I just want to close with a Canadian image. I think most of the time we act a little bit like this man in the rowboat. We're very good at seeing where we've come from, see the shore behind us, but I think it's high time that we got into a canoe and went forward and tried to see around the corner instead of just looking back. So I'll stop there.